This is Diagnostic Processes of Alzheimer's and Dementia, and I'm Katie Mitzloff.
I'm Bethany Miller.
I'm Lynn Chandler.
And I'm Sarah Vega.
Alzheimer's is an irreversible form of dementia, meaning there is no cure and it will progress over time, while dementia is an umbrella term that describes the symptoms. According to Derek Jones of Griswold Home Care, the symptoms include changes in memory, thinking patterns, vision, language, reasoning, judgment, and attention. In order for dementia to be diagnosed, the changes in these symptoms must be significant enough to interfere with a person's life and ability to function on their own. As opposed to that, Teresa Burracino and Jeremy Kay, authors of the article Early Diagnosis of Alzheimer's Disease and Mild Cognitive Impairment, a person diagnosed with mild cognitive impairment, or MCI, show independence in daily life activities like dressing themselves and eating. Only mild impairment in one or more of the symptoms. People with MCI are at risk for developing dementia. MCI can be classified into two subcategories. They are amnestic and non-amnestic. Amnestic refers to cognitive impairment that shows memory loss, but a normal level of functioning, while non-amnestic refers to cognitive domain other than memory, while the person still has a normal level of functioning.
Dementia is not a diagnosis within itself, but rather a range of neurocognitive symptoms that indicate global decline in cognition. The most common disease that dementia is associated with is Alzheimer's, but close behind are vascular dementia, Lewy body disease, frontotemporal dementia, and alcohol-related dementia. As I said, dementia in itself is not a disease, and it is not normal cognitive decline associated with normal aging. The diagnostic process of dementia begins with the general questioning of a patient's cognitive abilities. The DSM-5 states in its criteria that evidence of significant cognitive decline from a previous level of performance in one or more cognitive domains is present, such as complex attention, executive function, learning, memory, etc. And the evidence should consist of concern of the individual or a knowledgeable informant or clinician, a substantial impairment in cognitive performance, preferably documented by standardized neuropsychological testing, or if neuropsychological testing isn't available, another type of qualified assessment. It's marked by interference with independence in everyday activities, like activities of daily living, paying bills, or managing medications. The cognitive deficits don't always occur exclusively in the context of a delirium and are not better explained by a mental disorder.
Those who have a family history of Alzheimer's and dementia are at a greater risk for developing these diseases. Global Medication Education states that 60% of people with early onset Alzheimer's have no recognizable symptoms, and by the time the family notice or the patient is evaluated by the doctor, the dementia is in the moderate stage. Global Medical Education also states that neuropsychological testing is sometimes necessary for screening dementia. The Mini Mental State Exam, or MMSE, is one of the most common instruments to screen for dementia. However, driving skills need to be assessed as well in those suspected to have dementia, but the MMSE does not assess driving skills. And according to Burracino and Kay, the MMSE can be insensitive to the subtlety of MCI impairments. According to Burracino and Kay, early onset Alzheimer's typically sets in before the age of 65, but in some cases where the genetic mutations are present, the Alzheimer's can set in as early as before the age of 50. Early onset Alzheimer's is genetically similar to late onset Alzheimer's, but occurs in 1 to 2% of those who have Alzheimer's. Burracino and Kay also say that the three genetic mutations in early onset Alzheimer's are the APP gene, penicillin gene 1, and penicillin gene 2. The APP gene only needs to be present in one parent for it to be passed to their offspring. Together, these three genes make up for less than 10% of early onset cases. A proteoprotein E gene, APO4, is the gene associated with late onset Alzheimer's. Burracino and Kay say it is 3 times more likely that someone who carries the APO4 gene from one parent will develop Alzheimer's, and is 15 more likely if the APO4 is carried and given to the offspring by both parents. In addition to that, those who carry the APO4 gene will also develop Alzheimer's at a younger age. The research for APO4 is still limited, even though it was discovered about 15 years ago. Typically, the genetic testing for those with the genes are reserved for those younger than 65 and have already experienced the onset. Although the data is limited, it still remains a major focus on research in geriatrics, especially with new technological advances.
This new technology, measurement of biomarkers, is being touted as 100% accurate. You'll find the hyperlink in our discussion post to watch a video on DeMeyer's study on this new diagnostic tool. It yielded 36% positive results in the cognitively normal group, as you'll hear in the video, and this is not a guarantee. Therefore, if even a third of that group does not develop Alzheimer's, you've incorrectly diagnosed 12% of your patients. In Political Drive to Screen for Pre-Dementia, Couture and Doust argue that because increased age can reduce the reliability of the test, and that around 65% of people over 80 have amyloid imaging abnormalities, that could completely skew results in diagnosis, and this technique is not beneficial. Because this older cohort makes up the majority of people suffering from undiagnosed Alzheimer's and/or dementia of some form. Are we really benefiting them, or are we just scaring a generation who might develop this disease?
In the article, Clinical Implications of the New Diagnostic Guidelines for Dementia, published online in the May-June 2013 journal, Innovations in Clinical Neuroscience, they review the implications and possible solutions of the new diagnostic guidelines for dementia. The criteria now reflects how Alzheimer's disease is on a continuum because it is now seen as starting earlier and progressing over a longer period of time. This continuum is shown over 3 stages: pre-symptomatic, symptomatic, which is also known as mild cognitive impairment due to Alzheimer's disease, and the third, Alzheimer's disease or dementia phase. The strengths of this article is that it summarized all parts of the new guidelines, even if the point referenced, such as biomarkers, were not the main topic. It is a very thorough article so that anyone can read this and understand dementia and the new guidelines. The main implication in dementia diagnostics that the article explains is to decide if a patient's signs of diseases and symptoms are enough to diagnose them. This is because the psychiatrist is essentially taking away their independence, and it can negatively affect the patient. Another implication is when a patient is in the second stage, the mild cognitive impairment stage, and they do not want to keep going forward with diagnostics to see if they will most likely develop Alzheimer's disease. What the psychiatrist can do in this case is let them know that they have access to predictive testing and research experiments that they can participate in. Second, be prepared for those who deny it or have difficulty seeing anything but negativity out of the diagnosis, and respond in the best way for their well-being. Since it is now possible with the criteria to diagnose earlier, many patients seek greater access to prognostic findings and possibly effective treatments earlier. However, this is usually only available through research. The strengths of this article is that there is not any real implications stated about the guidelines and criteria of dementia diagnostics. Instead, the issue seems more with the patient and how they decide to process the life-changing news. The articles first began by outlining all the new guidelines to dementia diagnostics and then continued with methods on how to deal with these challenges. Weaknesses of this article is that it is very short and not thorough enough. Many more ideas and concepts that are named need to be explored.
This article by Bunn et al. Talks about a study that was done to help understand how people were diagnosed with dementia and how their carers treated them when they were diagnosed. It follows their life and the reaction to the diagnosis. The study started that most of the time people who are diagnosed or the carers are in denial of the diagnosis of dementia, but usually do not get diagnosed until the late stages of the disease. These qualitative studies are the researchers' interviews with patients, families, and other doctors. This study researched 102 studies that have been done over the diagnosis and reaction of people with dementia. When you tell someone they have dementia, everyone will act differently. Each family member may be reacting different, which can cause the revealing the information difficult. The study found that the transition after the diagnosis is very troublesome. It can cause a lot of conflict between the patient and their caregiver. This is a great place for a professional to step in and give our advice and help our patients. One thing that I thought was very interesting was that the spouse that is diagnosed with dementia, usually the other spouse turns into the carer. This can and usually makes a healthy spouse have health problems on their own because they are not used to being fully dependent on for everything from their spouse that has dementia. It is important to know that when you are working in a field and working with people with dementia, You should not only be trying to help that patient, but it is important to spend time with the family, get to know them, and make sure you are able to help them with any struggle or hardship they may be going through. It is important to understand how to communicate to people when giving them information, advice, or being there as a supportive system. When you are in the field working with individuals with dementia or other brain diseases, you should be as educated in that field as possible. Families will want to their loved ones to be in the hands of someone who knows about the disease and how to help their family.
These next two slides are our resources, and thank you for listening.